So normally insulin can be used in isolation. I mean, insulin only therapy, or in supplement of oral hypoglycemic agent. And we should be knowing that when to start insulin. Normally uh, type 2 diabetes, is insulin resistance, but also the beta cell dysfunction. Over period of year, every year, certain percentage of beta cells become dysfunctional because of aging, wear and tear mechanism. So, in due course of time, we all see practically many patients, in spite of the best oral hypoglycemic agents in best possible doses and best possible combinations, would not respond to therapy. And in such cases, we need to augment our management, and insulin is often introduced in those situations. Where there are specific guidelines when insulin uh, uh, can also be introduced early, not necessarily when the oral hypoglycemic agents have failed or we have exhausted all the options of oral medication. And if you look at the guidelines, largely from the American Diabetes Association, there are guidelines from the European group, and also American Endocrine Association, as well as endocrinologists. So these are the most of guidelines which were mostly followed, and these are the resources from which this particular article of American Family Physician have drawn the recommendations. So it can be used in combination with the oral hypoglycemic agents, and when especially blood sugar level is above 300 or 350, or HbA1c is above 9, different guidelines, but largely I'm practical things, then it is advisable that insulin is introduced. These guidelines are discussed, will be discussed later in due course. So practically speaking, there are two stages of insulin use. One, when there is a high HbA1c, which is 3-month average of sugar, which we regularly follow, or there is some symptom or sign of hyperglycemia or catabolism. So practically speaking, if HbA1c is above 9, or there are symptoms of hyperglycemia or catabolism, for example, there is severe weight loss, or having severe weakness, or ketones in urine. These are the situations where we have to think early, and we do not think in terms of exhausting the oral hypoglycemic agents, and we have to introduce insulin practically at an early stage. So these are the goals which you can see on the screen. So normally, for practical purposes, I would say keeping HbA1c, these are the target levels of insulin or oral hypoglycemic or overall diabetic management. Target HbA1c in a normal healthy person, young person, should be less than 7. Practical things. But if the person is frail or already having end organ damages, microvascular complications, or elderly, bedridden, poor nutritional status, then we have to be slightly liberal in our targets and goals of insulin management. And then the goals can be even 8 HbA1c or 8.5 HbA1c is reasonable. So strict insulin or sugar levels or HbA1c level management is only recommended when the person is healthy, and there is relatively lack of any chronic disease, uh, or person is fully conscious oriented control of self, and uh, can normally respond, or tritate or self monitor glucose. Those situations we talk or think of strict sugar management. and the goal is between maintaining sugar levels between normally 90 to 130, or HbA1c around 7 or less. But if there are complications, or chronic illnesses, two or more chronic illnesses, then the recommended level is between 90 to 150 of sugar levels, and HbA1c level around 8 or below. And if there are long-term conditions and end-stage chronic diseases, in those situations, and patients are very frail, nutrition is poor, then the target level can be anything between 100 to 180, or HbA1c 8.5 or below. So, these are the broad things we should keep in our mind when we are talking or thinking of, introducing insulin.